It's a pleasure to be here this morning. It's my first time talking to this group, and I'm really very proud to be here. So we're going to talk about, as was stated, LBD, Lewy body dementia, versus Parkinsonian disease dementia. And you'll see, as I go back a slide, please, to the title. I called this Parkinson's disease dementia, Lewy body dementia is two sides of one coin, or would have been a tale of two proteins, alpha-synuclein and tau, but we're not going to do that because we don't have enough time. Next, please. So let's talk about alpha-synuclein. Alpha-synuclein is a protein that is responsible to a large degree, though it also works with a tau protein, but it causes dementia because the alpha-synuclein levels are found to be part of a differential diagnosis of Lewy body dementia, or LBD, and there are other dementias secondary to neurodegenerative disorders where the nervous system isn't working correctly. Alzheimer's disease is the most common neurodegenerative disorder. It is more tau-related, but Lewy body dementia, most people don't realize, is the second most common dementia. And it's rarely heard. I think most people first heard of this when the comedian Robin Williams, I think, was found to have this disorder. Lewy body disease is diagnosed by the accumulation of Lewy bodies and Lewy neurites, which essentially is an overtaken nervous cell. And these are composed, and not to talk about the gobbledygook there, but aggregated phosphorylated alpha-synuclein. It's misfolded, so it doesn't work correctly. And the accumulation of this alpha-synuclein in areas that I'm going to show you right now that are called Lewy bodies that prevent nerve cells from working correctly. A meta-analysis, what that means is they take a lot of studies and they mishmash everything together and come out with one set of statistics. So a meta-analysis was performed on the reliability of finding alpha-synuclein levels in the cerebral spinal fluid. Okay, that's the fluid in the back and around the brain. Okay, when you get a lumbar puncture, they're taking out cerebral spinal fluid. Okay, so what you know is cerebral spinal fluid levels of alpha-synuclein are statistically different than that in Lewy body dementia. So there is a difference that you can tell by drawing cerebral spinal fluid and looking at Lewy body dementia versus Alzheimer's dementia. However, the amount of alpha-synuclein in the cerebral spinal fluid is pretty much the same. It's not significantly different between Lewy body dementia and dementia in Parkinson's disease, MSA, or multiple system atrophy, frontal temporal dementia, or progressive supranuclear palsy. Lewy body dementia and Parkinsonian disease dementia, PDD, are clinically similar. But after the dementia is seen, basically what you're going to hear in a little bit is in Parkinsonian dementia, things work a little differently. Tremor at rest has a lower incidence in LBD than in Parkinson's disease. And signs of Parkinsonism are in LBD are more symmetric, whereas when a patient develops Parkinson's disease, it may be asymmetric. You may have more tremor in one hand than the other, and so on. Patients with Parkinson's disease are typically less invested in their visual hallucinations, whereas patients with LBD, Lewy body dementia, are very much into and dealing with these hallucinations, the visual hallucinations. So that is a difference. Fluctuating cognition, which is extremely important, and we'll talk about that in a little bit, was first described more than 30 years ago. And it is a core diagnostic feature of Lewy body dementia, meaning that fluctuating cognition is part of the definition or the diagnosis of Lewy body dementia, but not Parkinson's disease dementia. Next, please. So here's some pictures. Here's one picture of a Lewy body. There's a picture of a similar Lewy body up top, but then in the middle of the slide, you see different types of Lewy bodies. Here's a brain of a patient with Lewy body dementia, and you can see how it is atrophied and very deep sulci between the gyri, between the nerves. And you see on the right, when they biopsy that, you can see the Lewy body. And here is an MRI of a patient with Lewy body dementia. Okay, you can see a lot of atrophy, and you can see ventriculomegaly, how the ventricles, the lateral ventricles in the middle of the brain, are enlarged. Partly that's because of the atrophy in the brain, but there are other reasons also. Next, please. LBD is the term I'm using for Lewy body dementia. It's found only in two different disorders, the first being Parkinson's disease dementia, and the second being dementia with Lewy bodies. Both forms show cognitive impairment secondary to the buildup of protein clumps, the alpha-synuclein that gets misfolded, not workable, so it becomes just that clump of circular protein that you saw in those slides, and this is what are called Lewy bodies. It may be similar to other dementias in a couple of ways, similar such as Alzheimer's disease, but LBD can show more aggressive, cognitive decline and fluctuating symptoms, and we'll get into that next. There are three stages to Lewy body disease, or dementia. LBD develops over time as these protein bundles, the Lewy bodies, accumulate in the brain. The gradual onset of dementias is typical of all dementias. You don't become totally demented the day after something happens, okay? LBD has the three stages: early, middle, and late. Next. Early stage LBD may not be obvious to you because it mimics natural age-related cognitive deficits, which may be minimal. I forgot the name of this person. I forgot to put where my keys are. So these are the things that are typically maybe age-related that has nothing to do, you think, with Lewy body dementia because it's mimicking natural age-related deficits. Next. Middle stage of dementia can be defined by symptoms that are not attributable to age, stress, or other issues at all. Okay, there's no attribution. The patient may need help with personal care and may have somebody that is full-time or part-time to help them do that. You may start noticing behavioral changes at this point, and these are specifically wandering. Patients will wander away, or repeated questions. They'll ask the same question of you multiple times, okay? Now, this is important. In LBD, sleep disorders are common, and actually this one sleep disorder called REM sleep behavior disorder, REM is rapid eye movement, and this occurs during dreaming. But with LBD, during REM sleep behavior disorder, patients act out. They can get up and walk, they can talk, flail, even fall out of bed, okay, during this REM stage. Again, REM is rapid eye movement. Next. In late-stage dementia, there's a dependency that has been developed. The patients need full or part-time care almost always, and they need that during their daily life as the symptoms can impair both physical and mental function, so they become less and less able to take care of themselves. Okay, so an additional person is needed. In LBD, behavioral symptoms become worse as the condition progresses. Along with classical dementia memory symptoms, you may see significant changes in the body secondary to inadequate central nervous system responses. Next, please. LBD is defined in part by the presence of fluctuating cognition. This is very important for the diagnosis in a way. Unlike other dementias, okay, cognitive changes in Lewy body dementia may come and go It may wax and wane. One day the patient will come and be very confused. Their thinking is obviously not up to par, and they're not able to tell you anything particularly normal. But with fluctuating cognition, the next day they may be perfectly fine. This is the only type of dementia where you see that. Now, the issue of fluctuating cognition is there in phases or stages 1, 2, and 3, early, middle, and late. So therefore, even though it's there, because it's there in all stages, it doesn't help in staging, being able to say, this is a patient with LBD in middle stage. You can't do it because it's in all 3 stages. Next. In the early stage, patients can have visual hallucinations, they can have motor changes, and most of them have task-oriented cognitive changes. They want to do something, but they're not able to do what they want to do. Next, please. In the middle stage, you'll see communication challenges, sleep problems, wandering. Remember we talked about wandering, repetitive questioning again, confusion, even if the patients are in a familiar setting, which is unusual. Memory loss, as you would think, trouble walking, muscle tremor, postural rigidity, reduced facial expressions. Where do you see those 4 things? In Parkinson's disease, right? Reduced facial expressions, as I said, visual hallucinations, cognitive fluctuation, as we discussed, mood fluctuations. Next. In the late stage, things pile up. You see depression, anxiety, paranoia. That's a big one. Delusions, agitation, very hard to control. That's where the medications that Dr. Harp was talking about earlier may be necessary. Severe memory loss, sleep disorders, the REM behavioral disorders, hallucinations, sexual dysfunction, and I believe that was also mentioned earlier this morning, motor dysfunction, limited ability to move, inability to communicate. They can't have a conversation. Dizziness, fainting and falling, losing consciousness for seconds to minutes. Temperature sensitivity, urinary incontinence, constipation, diminished sense of smell. And I'm reading all these because you need to understand this is not what you see in the other types of dementias. Next, please. Blood pressure changes and our friend, fluctuating cognition. Again, that is something that helps with the diagnosis of Lewy body dementia. Next. Now let's look at the core clinical features of Parkinsonian disease dementia and compare them to Lewy body dementia. So here are the core clinical features. In Parkinson's disease dementia, there are cognitive deficits. They need to have at least 2 of the 4 that we're going to talk about. Impaired attention. That can fluctuate. It can be good one day, bad the next. Executive functioning, the ability to make plans, the ability to carry out what you want to do. This is from the frontal lobes of the brain. Visual spatial functions are abnormal. They're not able to follow that. Impaired free recall memory is not uncommon in these patients. But these are the 4 core clinical features of Parkinson's disease dementia. The presence of at least one behavioral symptom, apathy, depression, anxiety, hallucinations, delusions, and anxiety, excessive daytime sleepiness. That's an interesting one, but it is commonly seen. And you'll see this all supports the diagnosis of probable PDD, probable Parkinson's disease dementia. And at the same time, there's a lack of behavioral symptoms. When you see a patient, it doesn't mean that they don't have Parkinson's disease dementia. Depends on the day. Next. No, I'm sorry, go back. We didn't talk about LBD. First 3 issues occur frequently and persist throughout the course of LBD. First is fluctuating cognition with pronounced variations in attention and alertness. Second, recurrent visual hallucinations that are typically well-formed and detailed. That's important because many patients and Parkinsonian disease dementia, you can see hallucinations that are not particularly well controlled. All right, they may be sort of different colors here and something there that looks like something else, but this is different with Lewy body dementia. REM sleep behavior disorder, as I told you, that is part of the diagnosis of Lewy body dementia. It is not seen in Parkinsonian disease dementia. Okay, one or more spontaneous of the cardinal Parkinsonian symptoms: bradykinesia, slow movement, rest, tremor at rest, and rigidity of the muscle. Next, please. So the core central features in Parkinson's disease for diagnosis of Parkinsonian disease dementia, these patients need to have the diagnosis of Parkinson's disease, not what you would, of course, that's what you would think. And with that is a dementia syndrome with impairment in more than just the cognitive domain. All right. In other words, when this starts, they don't necessarily have to have the decreased memory that is so common, okay, in dementia. You can see impaired attention, executive, dysexecutive activity dysfunction, visual spatial dysfunction. They're not able to do and touch and pick things up as easily as they should. And impaired free recall memory. Now, for LBD, for diagnosis, you need dementia in the early stages with memory impairment, but not necessarily will you see decreased memory first. You can see first deficits in attention, executive function, visual spatial activity, and the ability may be prominent, and this would occur earlier in many patients than decreased memory, which is what you'd expect in a dementia situation. Next. All right, supportive clinical features. In Parkinson's disease dementia, you will see features which do not exclude Parkinson's disease dementia or PDD, but make the diagnosis uncertain. This is important in how do you diagnose something. It's unfortunate, but you have a patient with Parkinson's disease and you think things are not going the way they should cognitively, but you're not sure of what type of dementia this is. So what you can see in PDD, there's a coexistence of other abnormalities which may by themselves cause cognitive impairment, such as changes in vascular abilities or vascular disease, which you see on imaging, particularly SPECT and PET scans or even MRI scans or angiograms. There's a time interval between the development of Parkinsonian disease dementia and cognitive symptoms, and you don't know what it is. They have to occur within a year. If that doesn't happen, that makes the diagnosis of Parkinson's disease dementia uncertain. In LBD, you have severe sensitivity to antipsychotic medications. I want to talk about that for a second. You can have the malignant neuroleptic syndrome, about 3.2%. And I bring it up even though it's a small amount is because I've seen it. But it is more particular for LBD than it is for Parkinson's disease dementia. If you use any type of antipsychotic to control activity in these patients, they may develop the malignant neuroleptic syndrome, which involves very high fever, over 104, muscle rigidity, increased problems thinking, and these patients need to be placed immediately in the ICU because very severe morbidity or problems, medical problems, and mortality. These people can die from this. So it must be treated extremely carefully and very quickly. Postural instability, inability to stand for a while, they'll fall over. Repeated falls, syncope or transient loss of consciousness. They can fall onto the ground, okay, for no reason that you can think of, okay? You're just sitting talking to them and they can fall. Syncope, severe autonomic. The autonomic nervous system, I think, has been talked about a little with almost every speaker. Basically, the autonomic nervous system is what enables us to breathe without thinking about it. It enables us to do a lot of things that we don't need to think about. Okay, and what you see in Lewy body dementia, because of changes in the autonomic nervous system, are things like constipation, orthostatic hypotension, which is decreased blood pressure, and urinary incontinence, which is these three things are from autonomic nervous system dysfunction. Hypersomnia, increased wanting to sleep. Hyposmia, their ability to smell decreases. Okay? Systematized delusions, right? Apathy, anxiety, depression are seen again as supportive clinical features. Next. In PDD, Parkinson's disease dementia, features suggesting other conditions or diseases are a cause of mental problems or mental impairment, which when present make it impossible to accurately diagnose Parkinson's disease dementia. So one of the things that I want you to understand is that Parkinson's disease dementia is not as easily determinable as Lewy body dementia. Okay? Now, cognitive and behavioral symptoms appearing solely in the context of other conditions such as acute confusion, secondary to either systemic diseases or abnormalities, drug intoxication, or severe depression, severe depressive disorder. All these things can cause that problem. Many of you may or may not know that a severe depressive disorder can look like a dementia, but it is not. In LBD, you see changes in a chemical basis, decreased ability to transport or move the chemical dopamine. You know dopamine, importantly, for Parkinson's syndrome. When you have a loss of dopamine, that's when you see Parkinson's disease, substantia nigra, and all those things that you know very well about. You see an abnormal uptake of, or it's very low, that's what's abnormal about it, of 1,2,3 iodine MIBG, myocardial scintigraphy. So that's looking at what happens in the heart to these chemicals. And lastly, polysomnographic. A polysomnogram is a sleep study that you may or may not have had. Many of you probably have or know somebody that has. And this confirms the REM sleep disorder that we talked about. Next. In Parkinson's disease dementia, there are no supportive or indicative biomarkers. Someone talked, I think Dr. Hart, about what a biomarker is. Okay. And biomarkers are found in association with Parkinson's disease dementia and Lewy body dementia. And basically, there's no supportive or indicative biomarkers needed for the diagnosis of Parkinsonian disease dementia, whereas there are for Lewy body dementia. You can see preservation of certain parts of the temporal lobes, generalized low uptake on the SPECT scans, okay, of certain types of metabolisms of different drugs. And you see prominent changes in the EEG, particularly in the alpha and theta range. There are 4 different types of activity that you would see on an EEG, and only 2 of them are impacted here. Next. The diagnosis of probable or possible Parkinsonian disease dementia. Probable core features. We talked about the core features. You must have Parkinsonism, and secondly, they must have dementia. They can have associated clinical features, including typical profile of cognitive deficits and the presence of at least one behavioral symptom. Lack of behavioral symptoms, however, do not exclude the diagnosis, because when you see them, they may not be obvious, but the next day, the next week, they may be obvious. So you can't make that diagnosis on the basis of whether or not they're the behavioral changes. In LBD, probable LBD, you have at least 2 core clinical features of LBD, which we talked about, the core clinical features, and they have to be present with the presence of indicative biomarkers, or 1 core clinical feature is present and 1 indicative biomarker. LBD, however, Lewy body dementia, should not be diagnosed on the basis of the presence or absence of biomarkers. Next. For possible PDD, Core features must be present. We talked about that. Associated clinical features are needed. Okay, and these may include atypical profile of cognitive impairments in one or more domains, including now fluent aphasia. You know, an aphasia can be either receptive, you can't understand it, or expressive, you can't speak. And this is a fluent aphasia. They can speak okay and very well. Or they can have a pure storage-related type failure of amnesia. They can't take in and remember enough information to make a difference. If it's new information, it's not that difficult to upload into the brain for these people old information. And this is something you know. So what else? I think the other domains include fluent aphasia, pure storage, and behavioral symptoms may or may not be present, as I told you. It depends on the day. And then with LBD, possible only one core clinical feature of LBD is necessary or present with no indicative biomarker. Or you can have one indicative biomarker present, but there's no core features